When are we taking the boat out again? I love sailing more than anything. If Thea had been a boy.
Okay, let's, any questions that have come up in the last hour? Okay. Let's jump into, finishing the urinary system. Like I said earlier this morning, exam 2 it will open later tonight, and it will cover the endocrine system, the respiratory system, and the urinary system. Also, the 4th lab quest is open, and it's covering lab exercises 36 and 37. Your second case study will be posted over this weekend. And what else? I think that's about it. You're going to find out that the fluid, electrolyte, and acid-base balance is actually a very short chapter. Because a lot of what we're covering with the respiratory system and the urinary system have to do with the chapter 24, fluid, electrolyte, and acid-base balance. A lot of it is a review of the respiratory system and the urinary system. And so it's actually a fairly short chapter. So we will start it and finish it next Friday and move on into the digestive system. Chances are I'm going to put the reproductive system into one PowerPoint rather than separating out the male and female reproductive systems. And I'll combine those labs also. Any questions, concerns? Can you hear my really vocal cat? It's kind of quiet because he's on the other side of the apartment. But he loves to test out the acoustics in the back room. As I see Kevin with his cat right there. So this filtration membrane, the renal corpuscle, remember, it's like this ball of capillaries. Glomerulus meaning a ball of string. It's got a lot of surface area to it. And surrounding each of these capillaries are smooth, modified smooth muscle cells that contain podocytes, which are foot processes that are also surrounding these capillaries. So the filtration membrane by which the plasma is going to be filtered and the filtrate is going to enter the capillary space right here. And right here. This membrane is made of 3 layers, from superficial to deep. Is that right? What, you know what, this should be deep to superficial. This is a typo right here. This should be deep to superficial. I'm looking at that, realizing that doesn't sound quite right. Podocytes are on the outside. Fenestrated capillary endothelial cells are lining the capillary, the internal lumen of the capillaries. So we have fenestrated capillary endothelial cells. Remember that there were 3 types of capillaries. There were continuous ones, there were fenestrated ones, and there were sinusoidal ones. The fenestrated ones are the medium holy kind. So the sinusoidal have a lot of holes, a lot of leaks. Continuous have no leaks. They're the tight junctions in between the endothelial cells, no leaks. So the fenestrated ones are intermediate, where they have some holes in them, which allows for small dissolved solutes to pass through the membrane and pass through the capillary membranal inner membrane walls. So solutes such as glucose, amino acids, small proteins, nitrogenous waste like urea and ammonium ions, creatinine and uric acid are all going to be able to pass through the glomerulus and enter the capsular space. Surrounding the endothelial cells of the capillary is the basal lamina. And on the external surface of the capillaries are the podocytes. So bear with me. I'm going to do a really crude drawing here, and we'll see it again in a moment. But so here's my capillaries. And this is just one section of one glomerulus capillary. One section. Remember, this is a bundle. Glomerulus is just a ball of capillaries. So this is one section. And actually, I'm gonna recreate it differently, because if it's fenestrated, this isn't gonna work. So it has, rather than being a continuous capillary, it's got a bunch of little leaky spots in it. That's a section of a capillary. And then, so these are the fenestrated endothelial cells. And then I have the basal lamina on top of that. And it's actually incomplete in a fenestrated capillary. It's kind of like that. So that's my basal lamina, the blue. And then outside of this, kind of overlapping, the capillary, are these podocyte or foot processes. So bear with me here. I'll label this drawing here. Fenestrated endothelial cells. That's a terrible line. Let me redo that one. Basal lamina. Basal lamina. And the most outer layer are the podocytes. That are essentially modified smooth muscle cells. So they're extensions of modified smooth muscle cells. And so what this means is that I have these vessels that have a lot of different little holes in them. That if a solute can move from the internal part of the capillary and manage to leak through all of the different holes, it will end up in the filtrate. Whatever is too big to be able to leak through all of the different pores of this capillary will stay within the blood. That's why we like this filtration membrane, is it's going to decide what gets filtered out into the kidneys and becomes part of the filtrate in the nephron, and what remains in the plasma. The filtration fraction is how much of the plasma that gets filtered through the glomerulus actually enters the capsular space and becomes a filtrate. And approximately 20% of it will be filtrate. So about 20% of all of the plasma that enters the kidney will become filtrate in the nephron. The looping structure of these capillaries, remember they're a major just ball of capillaries, is going to have an increased filtering surface area, lots of surface area to allow for lots of filtration. So the filtration, the glomerular surface area of your capillaries, of your glomerular capillaries is approximately 3 meters squared per, I'm guessing per nephron, but I'm not sure. Which is a lot. If you think about that, that's a lot of surface area. So the increased surface area makes filtration through the stack of the different filters, these different layers, very, very efficient. So most formed elements, this is just looking at this a different picture. You saw my really crude drawing. Here's your endothelial cells with the fenestrations, the little holes in them. Here's the basal lamina. And here's the podocytes. Whatever can make it through all of the little holes will enter the filtrate. Whatever doesn't make it through all of the little holes is going to be confined within the blood and will not enter the kidney nephrons. So formed elements like blood cells and most proteins like albumin are too large to fit through the filtration slits, all these little pores. Water and other small solutes like amino acids and uric acid and nitrogenous waste and creatinine and amino acids and glucose and water and lots of different ions are all going to end up in the filtrate. So this is a figure from your book showing transmission electron microscopy of this filter. Here's the inside, here's the lumen of the capillary. Here's a erythrocyte, a red blood cell. Here's the filtration slits. Bear with me, we're gonna zoom in just a little bit more. Here's the filtration slits in the endothelial cells. Here's the podocytes. So looking at this, another figure from your book, here's the podocytes. Here's the basement membrane or the basal lamina. Here are the endothelial cells of the capillary and their fenestrations. Things that are going to remain within the blood are the red blood cells, white blood cells, plasma proteins, large anions, meaning large negatively charged things, protein-bound minerals and hormones, and most molecules. Anything that's greater than 8 nanometers in diameter is going to remain within the capillary. Things that are going to end up in the filtrate are water, electrolytes, glucose, amino acids, fatty acids, vitamins, urea, uric acid, and creatinine. Last 3 of these are nitrogenous wastes.
So the uric acid and the creatine are, you said nitrogen, I can't talk, nitrogen waste.
Yes, nitrogenous waste. You can see why I sometimes bumble and mumble up my words.
Yeah. All right, thanks.
No, you're fine. I understand more than I can say. And the last one, I'm trying to remember, there's one more. There's one more nitrogenous waste. What is it? Ammonium ions. are also going to be nitrogenous waste. So blood plasma is filtered into what?
B.
V renal corpuscle, right, Rachel? So how quickly is it filtered? That's the glomerular filtration rate. So how much filtrate is produced per minute? So the filtrate formed by both kidneys per minute is defined as the glomerular filtration rate, which is about 125 milliliters per minute. Or the equivalent of filtering all 3 liters of plasma about 60 times per day. You can realize how vital your kidneys are when you think about this. Remember that approximately 60% or 50% of your blood is your plasma. So all of your plasma is going to be filtered through your kidneys about 60 times per day. What forces determine how much filtrate is going to be produced? The hydrostatic pressure, aka the blood pressure, the force of the fluid against the glomerular capillary walls is going to push water out of the capillary into the interstitial space. The colloid osmotic pressure, which is the pressure exerted by proteins that are not leaving the capillaries. The osmotic pressure exerted by these proteins to keep fluid within the capillaries. These are the 2 main opposing pressures. One is trying to push fluid out into the capsular space, out into the capsular space, out here. Oh, not out here, out here, out here. The colloid osmotic pressure is working to keep the fluid within the capillaries. So major driving forces, the glomerular hydrostatic pressure, aka the blood pressure, the glomerular colloid osmotic pressure, pressure of the osmotic pressure exerted by the proteins that are within the capillaries, and the capsular hydrostatic pressure, which is almost 0 all the time. Oh, okay, is it always 0? Bear with me here. It's usually very, very low. Why would it be very, very low? This is the pressure exerted by the fluid within here. Why would it be considered very low, the capsular hydrostatic pressure? Why would it be considered fairly low and not have a really big impact? What's happening to the fluid that gets the filtrate that gets moved into the capsular space? What happens to it next? What happens to it next? What happens to it next? It gets filtered out here, becomes part of the filtrate. Where does it go from here?
Does it get reabsorbed?
Well, it's going to get reabsorbed. Where does it get reabsorbed, Martin?
Is it
I'll say
the
back
renal?
into the blood.
Say it again.
Say back into the blood.
Where in the nephron does it move? Once it's, let me back up just a little bit. So it gets filtered out in the glomerulus. You're right, it's gonna get reabsorbed. But where do most of those things get reabsorbed?
The renal capsule or caps, however you want to say it.
That's where it's gonna get filtered.
Okay.
And then
So,
where
is it
does
the proximal convoluted tubule?
right. So all of this fluid that's getting filtered here is draining into here. And so the result is that the hydrostatic pressure, remember that's the pressure that's pushing on the glomerulus of the fluid that's already been filtered out, is very low because it just keeps draining out of the glomerulus, right? It doesn't stay there very long enough to really exert a severe pressure. I think to help this along, you'll see I posted a couple of videos. I don't know if we're going to watch them all, but I posted a few here. And I think talking about this right now, some of this is a review of what we talked about. Well, these are the same forces. You remember when we talked about the startling forces that are involved in fluid exchange and capillaries? Maybe. They're the same as these forces. So let's watch this video here about the forces of filtration and what regulates the glomerular filtration rate.
This is Katie. Katie just aced her med school anatomy.
Hi, in this tutorial, I'm going to discuss the forces of filtration which occur within the glomerulus. The forces we are going to be talking about are the forces that drive fluid and solutes out of the blood, across the glomerular capillary membranes, and into the Bowman's capsule. You may have seen these forces elsewhere in capillary circulation. They are often called Starling's forces. Now, in order to illustrate these, I'll begin by drawing a glomerulus. You can see the afferent arteriole here and the efferent arteriole here. And of course, in between them is the glomerular capillaries. And out here, we have Bowman's capsule. There are two types of forces at work here.
Bowman's capsule is the same thing as the glomerular or the renal capsule.
First is called hydrostatic pressure, which I'll write as a P with a small h. And this is a force that compels a fluid to move out of the vessel because it is contained within a vessel. To understand,
so this is the same as the glomerular hydrostatic pressure, or the AKA the blood pressure in the capillaries.
this, imagine a balloon with a small hole in it. As you blow up the balloon, there is more pressure within the balloon, and thus more air will move out of the small hole. The same is true for capillary hydrostatic pressure. the larger the volume of blood within the capillaries, and the higher the blood pressure, the more quickly fluid will move through the capillary walls and into the surrounding tissue. The second important force here is the oncotic pressure, sometimes called the colloid oncotic pressure. This is usually denoted pi. This is a type of osmotic force.
So it's the same as the osmotic force.
Which is exerted on fluids by the presence of proteins in the blood and tissues.
So that would be the colloid osmotic pressure.
Also, we'll use these forces to determine the net pressure moving fluid out of the glomerulus and into.
So one, the hydrostatic pressure is working to push fluid into the capsular space. The oncotic pressure, or the colloid osmotic pressure, is working to prevent fluid from moving out into the capsular space and keep it within the blood.
To the bone capsule. I'll denote this P net. So there are three forces acting here. The first is a hydrostatic pressure of the blood, which forces fluid out of the capillaries and into the Bowman's capsule. The second is the hydrostatic pressure of the filtrate, and this pressure compels fluid to move back into the capillaries.
So that's a capsular hydrostatic pressure. This one right here.
This can be a bit confusing, so I'll explain a bit further. Any fluid that is contained within a space exerts hydrostatic pressure on the boundaries of that space. So when the blood is filtered and the filtrate collects within the Bowman's capsule, the filtrate exerts pressure on the boundaries of the Bowman's capsule and the capillary bed within the capsule. As I said before, this compels fluid to move back into the capillary bed. The final force is the oncotic pressure, which also compels fluid back into the capillary bed. This is the
So the capsular hydrostatic pressure and the colloid osmotic pressure are both working to keep fluid within the capillaries. The hydrostatic pressure of the glomerulus, aka the blood pressure, is working to push fluid out and have that fluid become filtrate that's going to move into the capsular space.
osmotic force that the proteins in the blood exert on the fluid in the filtrate. Note that there is no oncotic force in the other direction, and this is because under normal circumstances, there should not be any significant amount of protein in the filtrate. Now for some specifics.
So the reason you don't have a capsular osmotic space is because you should not, if there's nothing wrong with your membrane here, you should not have any proteins being filtered out.
In a normal healthy adult, the hydrostatic pressure of the blood in the capillaries is about 55 millimeters of mercury on average. The hydrostatic pressure of the filtrate is about 15 millimeters of mercury, and the oncotic pressure is about 30 millimeters of mercury. This gives us a net pressure.
So what's the net filtration pressure? So what's the net filtration pressure? Add these together because they're working in
100.
Nope. It's not 100. Add these two oppose this one. right? This one is working to push fluid out. These are working to keep it in.
So would it be 10?
45. Mm.
It's 10.
So it's those two minus the other one. So it'd be 10.
Right.
Okay.
Now, what if for some reason you have less proteins within the blood? And so the osmotic pressure within the capillaries actually is less than 30. Let's say that it's 25. Then the net filtration pressure is going to go up, because if this is 25 plus 15, go ahead. 25 plus 15 minus 55, now the net filtration pressure is 45. Excuse me, net filtration pressure is 15 and not 10.
Pressure driving fluid out of the glomerular capillaries of about 10 millimeters of mercury. Now, I'll show you how that net pressure is calculated from those other pressures. The net pressure is the force out minus the force back into the capillaries. So if we substitute in our pressures, this gives us the hydrostatic pressure of blood minus the sum of the hydrostatic pressure of filtrate and the oncotic pressure. And then substituting our actual values in the equation and then solving gives us 10 millimeters of mercury. And that's an overview of the forces of filtration. If you've enjoyed this tutorial, please help us produce more by making a donation at www.handwrittentutorials.com.
So I'm not going to spend a lot of time on these, because if you go back and you look at that, we talked about startling forces with the capillaries before. If you go back and look at those, they are the same as these. Hi, come on, you gonna get over here? My cat, bear with me. You gonna show your face? He says no. No, I don't think I did this right. Just a sec. So major forces, both of these are going to, both the glomerulocolloid osmotic pressure and the capsular hydrostatic pressure are both going to oppose the glomerular hydrostatic pressure. And so the net filtration pressure is determined by taking the glomerular hydrostatic pressure, summing the glomerulocolloid osmotic pressure and the capsular hydrostatic pressure, and subtracting them by the glomerular hydrostatic pressure. Therefore, the net filtration pressure is going to favor filtration as long as the glomerular hydrostatic pressure is greater than the sum of the forces that oppose filtration. So looking at this one other way, glomerular hydrostatic pressure, 50 millimeters of mercury. The glomerular hydrostatic pressure favors filtration and drives fluid out of the glomerular capillaries. Opposing filtration are the glomerular colloid osmotic pressure and the capsular hydrostatic pressure that oppose filtration and drive fluid back into the capillaries. Therefore, the overall net filtration pressure is the sum of the forces that favor filtration minus those that oppose filtration. And it measures to approximately 10, in a normal person, approximately 10 millimeters of mercury of pressure. That's going to drive fluid out of the glomerulus. Any questions?
Can you go back up just one slide so I can write down the 3 driving forces? Right. Thank you.
Glomerulonephritis. Inflammation of the glomerular capillaries and the basement membrane. So I'm going to show my really crude drawing one more time of my capillary here. So what this means is inflammation of the fenestrated endothelial cells and the basal lamina or basement membrane. Basement membrane is also the basal lamina in this case. When there's inflammation here, meaning that there's going to be damage to the capillaries in the basement membrane. Only reason to have inflammation here, remember that it can be damaging. So this is going to result in damage and more holes in that membrane than what you want in your filtering membrane. So it's going to result in increased blood flow in those capillaries and increased permeability. And the result is that you're going to get increased glomerular hydrostatic pressure. Remember, that was a major force that's going to favor filtration. And the result is that the filtration membrane becomes really leaky, and there's a loss of blood cells and proteins in the urine. With me. So normally we don't have proteins in the urine. We don't have red blood cells in the urine. Well, with glomerulonephritis, all of a sudden these holes are a lot bigger than they should be. And we have red blood cells and proteins in the urine. So as this damage progresses, if the inflammation continues, the nephrons are destroyed and the glomerular filtration rate decreases, and which triggers compensatory mechanisms to further increase the glomerular hydrostatic pressure to maintain the glomerular filtration rate. And therefore, there's additional loss of cells and proteins, and the filtration rate cannot be maintained, and toxins accumulate, and this can lead to renal failure. Any questions? The major factor that determines the glomerular filtration rate, remember what it is, it's the glomerular hydrostatic pressure, is the major pressure that's involved in determining the filtration rate. So the result is that if you increase the glomerular hydrostatic pressure, you increase the filtration rate. So if I increase how much blood is coming in to the glomerulus, I'm going to increase the blood pressure within the glomerulus. And therefore, I'm going to increase the filtration rate. If another way that I can do this, or oh, actually, let me do it this way. So how do I do this? How would I increase how much blood is within here? Couple different ways. I can dilate the afferent arteriole that's bringing blood in, and therefore it just gets a lot bigger, and it allows more blood into the glomerulus, which is going to increase the hydrostatic pressure, aka the blood pressure, and that's going to increase my filtration rate. I can also increase the blood hydrostatic pressure by I can increase the hydrostatic pressure. Wait, I'm sorry. Okay, I can increase the hydrostatic pressure by constricting the efferent arteriole. Because if I can keep the blood in here longer, that's going to increase the pressure too. But typically we tend to work with the afferent arteriole. If I want to decrease the blood pressure in here, I can either dilate, I can constrict the afferent arteriole, or I can dilate the efferent arteriole. What will happen if I dilate the efferent arteriole? Vasodilation. I can't see any faces right now. What will happen if I do this?
It'll allow more blood to flow.
Flow where? Is it going to flow out of the glomerulus or stay in the glomerulus?
Out.
It's going to flow out. And so what's that going to do to the pressure within the glomerulus, Kevin?
Reduce it.
It's going to reduce it. And so that's going to reduce the hydrostatic pressure and therefore reduce the filtration rate. Good job. Yes. I can also, to decrease the filtration rate and therefore decrease the hydrostatic pressure, so I decrease the filtration pressure, is I can constrict the afferent arteriole. What will happen if I constrict the afferent arteriole? Remember, afferent meaning incoming, efferent meaning outgoing.
You lower the blood pressure?
Lower the blood pressure where?
They're on their arteriole.
Near the arteriole.
Yes.
And so if I lower the blood, but okay, I'm going to lower it. Actually, well, where is this? This is fluid moving in here. If I make this smaller, what happens to the amount of blood within here? Zena?
Will decrease the filtration rate, right?
Yes, because it's going to decrease the blood pressure, right? Does that
Yes.
make sense? All right. Same thing here. I don't know why they're showing the same both places, but they're showing it both places here. So there's different factors, and all are almost, they are all working on constricting or dilating the afferent arteriole. All of these different factors that are going to affect the filtration rate are working on the afferent arteriole, the blood coming into the glomerulus. The first one is the myogenic mechanism. What does myo mean? It's been a while, but what does myo mean?
Heart.
My means myo means muscle.
It means muscle.
And
There
muscle
is a
form of muscle.
there is muscle within the myocardium, and it's because it's really I'm sorry, myocardium meaning heart muscle. So myogenic, what does genic mean?
Originating from. or-
Originating from. So this is a factor that's inherent within the muscle. So similar to vasoconstriction. So these arterioles, remember what arterioles are. They have a lot of smooth muscle around them. Similar to arterioles in the systemic arterioles throughout the body. When there's an increase in pressure within those arterioles automatically vasoconstrict. You get an increased amount of pressure and they go like that. Oh, just like your rubber bands would do. Oh. And so that's what this myogenic mechanism is that increased systemic blood pressure is going to stretch that afferent arteriole. And that's going to increase the glomerular filtration rate for a minute temporarily. But because it's been stretched, all of a sudden it's going to constrict. And the result is that there's decreased blood flow into the glomerulus and a return of the filtration rate to normal. Is that clear? Since I can see some faces here, is that clear how that would work? We'll see in a picture in a moment here. Decreased systemic blood pressure is going to stretch the afferent arteriole less. So if the blood pressure drops, the vessel won't constrict, it'll relax. And so a reduced blood pressure will stretch that afferent arteriole less, which will decrease the filtration rate, triggering relaxation of the muscle around the arteriole. And the result is that there will be increased blood through the glomerulus and therefore increased filtration rates back to the normal. So showing this, here's your glomerulus. You constrict that arteriole. That's going to reduce the amount of blood flowing into the glomerulus, decreasing the hydrostatic pressure, which is going to decrease the glomerular filtration rate. If we dilate it, because there's not enough blood coming through, so the smooth muscle relaxes, it's going to increase the hydrostatic pressure, increasing the filtration pressure, and thus increasing the glomerular filtration rate. Another one, tubuloglomerular feedback. I'm going to back up. We're going to look at a slide that we saw a minute ago to explain this one. Okay, so remember this, how the distal tubule, distal convoluted tubule is essentially nestled right up against the afferent arteriole. You see that, right? It's nestled right up against it. It's nestled right up against it. This is going to be important. Right up against it. Now, why is that important? As the glomerular filtration rate increases, remember how the fluid is moving. It's moving into the glomerulus, then it's moving into the proximal convoluted tubule, then it's moving down the loop of Henle, then it's coming up and going into the distal convoluted tubule. So as the filtration rate increases, the volume flowing through the distal convoluted tubule is increasing. And more sodium and chloride are being reabsorbed into the macula densa cells that surround the distal convoluted tubule. In response to this increased reabsorption, the macula densa cells of the distal convoluted tubule respond by releasing chemicals that cause the afferent arteriole to constrict. So those cells that are that are part of the distal convoluted tubule, that are right next to the afferent arteriole, are secreting hormones, paracrines, that diffuse over to the afferent arteriole, inducing the afferent arteriole to constrict, reducing the net filtration pressure because it's reducing the blood flow into the glomerulus. The macula densa also signals the juxtaglomerular cells, which are going to cause a decrease in the release of renin. What was renin? Do you remember renin? Remember that renin, angiotensin, aldosterone system?
It's a hormone.
It's a hormone slash enzyme. It's actually it's a enzyme that acts like a hormone, but it's going to work to decrease blood pressure. If you reduce how much renin is being produced, renin is working on bringing up blood pressure. If you decrease how much renin is being produced, you're going to reduce blood pressure, reducing glomerular filtration rates. As the glomerular filtration rate drops, because you're constricting the afferent arteriole and reducing the release of renin, there's going to be less sodium and chloride being absorbed by the macula densa and the distal tubules. This will trigger a dilation of the afferent arteriole, restoring the glomerular hydrostatic pressure to restore the glomerular filtration rate. Look at this from look at the diagram that was in the blog showing this. Here's your distal convoluted tubule. Here's your afferent arteriole. Here's your efferent arteriole. Here is the macula densa cells. And we have mesangial cells that are within the glomerulus. So there's a high glomerular filtration rate. Therefore, there's going to be increased amounts of sodium chloride that are circulating and being reabsorbed in the distal convoluted tubule. The macula densa will secrete ATP. The mesangial cells metabolize that ATP. Adenosine is going to stimulate granular cells that are surrounding the arteriole, and the afferent arteriole is going to constrict, reducing GFR. Renin-angiotensin system, hormonal effects on GFR that are involved in the larger picture of regulating systemic blood pressure. The renin-angiotensin-aldosterone system is a complex that maintains systemic blood pressure primarily, and as a secondary effect, glomerular filtration rates. It's going to respond to 3 different conditions: stimulation by the sympathetic nervous system, low glomerular hydrostatic pressure, and stimulation from the macula densa cells in the distal convoluted tubule. So there's a drop in blood pressure. The liver produces this angiotensinogen, which is this long, elongated protein that's inactive. That ogen says that it's inactive. It's produced, it circulates, but until it's necessary, it's not activated. So it's moving around in the bloodstream. And when the blood pressure drops, renin is going to be released by the kidneys. Renin cleaves angiotensinogen to angiotensin 1. Angiotensin 1 then circulates around in the blood. And when it enters the lungs, as the blood enters the lungs, it contains angiotensin 1. It's going to run into this enzyme called angiotensin converting enzyme, or ACE. And ACE is going to convert angiotensin 1 to angiotensin 2. Angiotensin 2, through multiple pathways, is going to increase systemic blood pressure, and as a consequence, increase the glomerular filtration rate. So here's one more illustration of this. Systemic blood pressure decreases. Liver produces this angiotensinogen. Juxtaglomerular cells within the kidneys recognize that the blood pressure, the glomerular filtration rate has decreased because the blood pressure's decreased. And they release renin. Renin circulates, and when it runs into angiotensinogen, it cleaves it to angiotensin 1. As that angiotensin 1 circulates in the blood, eventually it's going to find itself in the lungs, because all blood does. And there it's going to be converted to angiotensin 2 by ACE, angiotensin converting enzyme. Angiotensin 2 is going to do 5 different things. It's going to promote the vasoconstriction of afferent arterioles. Vasoconstriction of efferent arterioles, promote the vasoconstriction of systemic blood vessels, increasing the blood pressure, through constricting the efferent arteriole here, it's going to increase the blood pressure within the capillaries of the glomerulus. If you constrict the vessel that's draining the glomerulus, the blood's going to stay in the glomerulus longer. It's going to promote reabsorption of sodium and chloride from the proximal tubule, and water follows. I think we mentioned this once or twice before, and I think I told you to write it down. Water follows sodium. If you reabsorb sodium, you reabsorb water. You guys, I'm going to mention this because this is really, 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 really important. Understand this. Water follows sodium. Water follows sodium. If I increase the amount of sodium being moved into a compartment, what does that do to the concentration of sodium within that area? If I have,
Wait, you just said if you increase the amount of sodium, you mean if you increase the amount of water?
nope, if I increase the amount of sodium, here I have two compartments. Okay. If I increase the amount of sodium that is able to go into this compartment, let's say that this is the lumen of the nephron, M-E-N, this is the lumen of the nephron, and this is the blood. If I increase the amount of sodium that moves into the blood, what happens to the concentration of different solutes within the blood? Remember, sodium is a solute.
Can you repeat that question? So if you increase the amount of solute,
If I increase the amount of sodium, which we know is a solute, and meaning it gets reabsorbed from the lumen into the blood. If I increase the amount of sodium that goes into the blood, what happens to the concentration of solutes within the blood?
increases because it will follow the water.
Well, no, wait, no. Water follows sodium. We're only talking about sodium here for 1 second, Zena. We're only talking about sodium. You're right. It's going to increase the solute concentration there. Now, what's going to happen with regards to osmosis if I increase the amount of sodium here or solute here? And now the concentration of solute here is much higher than here. Lots of sodium here because I'm pulling it into the blood. How is water going to move? I keep increasing the amount of sodium here. How is water going to move, guys?
It'll go from the lumen to the blood, right?
Why?
Because that's where you have all the solutes.
Right. Right. And sodium has the biggest effect on this. Sodium has the best has the best ability to increase osmotic pressure. That's why water follows sodium. Is that clear?
Yeah, it makes sense.
Good job, Zena. That was really good.
Yes, props to you, girl.
I'm sorry, I get a little.
Plus, I'm digging your hair today.
It's she says that's her mother hair, her mom hair, but
Yeah.
I think it's really pretty.
Thank you.
All right. I get a little intense with you guys, and I think part of it is because I'm tired, and part of it is because I'm like, get this, please understand this. So I'm sorry if I get that way with you. Don't take offense to it. So angiotensin 2 is going to promote the reabsorption of sodium. Chloride is going to always follow sodium as a balancing ion. And so sodium is going to be reabsorbed and water is going to follow sodium and chloride. Also, in addition to this, angiotensin 2 is going to promote aldosterone reabsorb. Excuse me, it's going to promote aldosterone aldosterone release. What does aldosterone do? You remember from the endocrine system?
Regulates blood pressure
How does it do it?
by controlling like how much your water or fluid or urine should be exerted out.
How does it do it?
Water and salts
What salt?
in the kidney.
Oh, well, yeah, salt in the kidney, but what salt?
Sodium chloride.
Yes. It's
Oh.
working on sodium the same way it's working on it, like Zena explained. Aldosterone works on sodium, knowing that water's going to follow. Last part that angiotensin 2 works on is it's going to stimulate the thirst center in the hypothalamus, which will increase fluid intake. You guys, you will like the chapter on the fluid, electrolytes, and acid-base balance, because a lot of it, like I said, is a review of this. So if it's not completely clear this week, it will be a lot clearer next week. So just keep moving along with it and plugging away with it. Drugs that influence the renin-angiotensin-aldosterone system to reduce blood pressure. Oh, you guys, bear with me, one more. Stimulates the thirst center in the hypothalamus. What is that going to do?
Does it also stimulate the anti-diuretic hormone?
Booyah. Yes. Yeah. So it works. Yeah, booyah. So anti-diuretic hormone. And what else does it do? It makes you feel thirsty. And the result is that you want to drink more water. Okay. So ACE inhibitors. Remember, this is the one that works to convert angiotensin 1 to angiotensin 2. ACE inhibitors. ACE inhibitors were developed from a snake venom to block ACE, inhibiting the conversion of angiotensin 1 to angiotensin 2. So these are anti-blood pressure medications. Another one is angiotensin receptor blockers that block receptors on blood vessels and proximal convoluted tubules, preventing them from constricting or reabsorbing sodium and water. The last one are aldosterone antagonists. Block the effects of aldosterone on the distal tubule, preventing sodium reabsorption, works on water. So that's why we really care about sodium. If you're going to have a favorite ion here, it's sodium. Because sodium does so many things here, one of which is maintain your water volume, which maintains your blood volume. We really, 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 really like sodium. So which of the following would reduce the glomerular filtration rate? And bear with me, I just had it, where did it go? Which of the following would reduce the glomerular filtration rate?
Is it maybe B?
B is in Bravo.
Mhm.
Why would that reduce it?
Because it's less fluid, because the other ones didn't make sense to me, because like A, I don't know, I'm playing elimination there, but vasoconstriction efferent, like the efferent doesn't, it's not affected, it's the afferent that's affected.
Well, it's gonna be affected, but if we're trying to reduce what we have when we're talking about reducing the glomerular filtration rate, we're talking about reducing the blood pressure,
Right.
So is it going to be vasoconstriction of the efferent arteriole?
Because if it, don't you like, if you constrict the afferent arteriole, I thought that's where it arrives, the fluid. So if you constrict it, then you won't have the fluid or blood coming in. But if you dilate it, then you'll have more coming in. Or am I-
So you're right. So which is the right answer? Let me ask you again, Zena, which one is the right answer for reducing the filtration rate?
Well, I guess vasoconstriction, because you're constricting it.
Which one?
So is it A then? Because that's saying
Wait, which one is the efferent and which one is the afferent? What does the efferent do? What does the afferent do?
the afferent is when it arrives, but the efferent is like what takes it away.
Right.
Right.
So which one is going to reduce the blood pressure?
The afferent one, I thought.
So which one's the right answer?
Oh, there is afferent there. I didn't see it. D, sorry.
You're right, D. I thought she's going to see it. I knew you would. Okay. Renin hydrolyzes angiotensinogen, which is released from what to form angiotensin 1?
Kidneys.
Renin is released from the kidneys.
Yep. And I'm not sure specifically what this question is asking, whether it's asking whether it's talking about angiotensinogen or whether it's talking about renin. Where's angiotensinogen coming from?
The liver.
Right. So kidney and then the liver. Okay. Next one, hormones that affect the glomerular filtration rate. Another one, atrial natriuretic peptide. What was that? You saw this before. What is it? It's coming from the atria in the heart in response to increased fluid volume. So increased stretch in the atria. When it's secreted, the result is that it's going to lower the blood volume and lower the blood pressure in order to reduce how much work the heart has to do. So atrial natriuretic peptide is going to lower the blood volume. Therefore, it's going to increase the glomerular filtration rate by dilating afferent arterioles and constricting efferent arterioles. The result is that you get increased glomerular hydrostatic pressure, which is going to increase the glomerular filtration rate, which leads to blood volume reduction, favoring fluid loss from the kidneys, and thus reducing systemic blood pressure. So if you increase the filtration rate, you're going to increase how much fluid is going to be excreted in the urine. And that's what atrial natriuretic peptide is working on. A neurohormone that affects the glomerular filtration rate, norepinephrine. Like most systemic blood vessels, norepinephrine causes vasoconstriction of afferent arterioles. Low levels of the sympathetic stimulation trigger the juxtaglomerular cells to release renin, which increases angiotensin II levels. The result is that you get increased blood pressure and increased glomerular filtration rates. High levels of sympathetic stimulation are going to increase angiotensin II levels that constrict both afferent and efferent arterioles. And the result is that you get reduced glomerular filtration rates, minimizing fluid loss and preserving blood volume. So increased sympathetic stimulation is going to work to increase blood volume and prevent fluid loss by decreasing the glomerular filtration rate. Remember that if we decrease the glomerular filtration rate, we decrease how much filtrate we actually produce. The more filtrate you produce, the more chances you have of losing water. And that means you're going to lower, if you lose water, you lower your blood volume. So an overview of factors controlling blood volumes. I'm not going to go through all these, but it's a review. So innervation of the kidneys reduces urine production, while the function of its blank innervation is unknown.
Maybe A,
Why do you say it's A?
because because of the sympathetic nerve system having to do with the blood flow. I don't know
And-
if I,
So you're right. So the sympathetic nervous system is going to work to decrease how much filtrate is being produced.
right,
Isn't the sympathetic nervous system the fight or flight?
Yep.
So that it decreases urine.
Yep. If you've
Okay.
ever noticed, I don't know if I've shared this story with you or not. So I lived in Arizona for a long time in the Phoenix Valley. And when I lived there, I used to, there was a mountain. It is like a flat area. If you've been there, it's flat. There's really no hills. You know, if you think Pennsylvania is flat, you have not seen anything, because Pennsylvania is not flat. Because Phoenix is really, really flat, but right in the middle of the Scottsdale Phoenix interface area, there's a big old mountain that's like a solid rock that just kind of juts out in the middle of nowhere. And it's called Camelback Mountain. And Becky's heard of it. She just nodded. And it's about 1.25 miles up to the top and back down again. And it kind of juts out of nowhere. And when I lived there, I used to love to run that mountain. And what I do is I drive over there, I drink like, a liter of water, maybe a little bit more. And then I'd run up to the top of the mountain, you know, and it's got a pretty good it's pretty steep, but there's a lot of handrails and so forth. And so I'd run up to the top of the mountain and then, you know, get up there, look around for a minute from the very top, because you can see all over the Phoenix Valley. It's really pretty. And then run back down again. But the second I got back to my car, I was looking for a gas station because I had to pee so bad. Because when you're working out or you see that bear in front of you, all of a sudden you have no need to pee until the threat is over or you're no longer working out like that. And maybe you've noticed that when you're working out aggressively, that all of a sudden you don't have to, you don't need to until you're done, and then you really have to go. For this reason. So renal failure. If the glomerular filtration rate decreases, kidneys may be unable to carry out their vital functions. It may be short-term, acute renal failure or acute kidney injury, or it may become chronic after 3 or 4 months of decreased GFR. It's commonly observed with long-standing diabetes mellitus and hypertension. Uremia can develop, meaning really low urine levels being produced, can develop when the glomerular filtration rate is less than 50% of normal. The result here is that you get a buildup of waste products, fluid, and electrolytes, as well as acid-base imbalances, because you're just not filtering things appropriately. Dialysis can be used to treat the signs and symptoms of uremia. Hemodialysis is a temporary removal of blood and passing it through a filter. Peritoneal dialysis is where dialysis fluid is placed in the peritoneal cavity and allowed to circulate for a set period of time. So hemodialysis, this temporary removal, you have about 12 pints of blood. So you remove about a pint of it at a time and filter it through a membrane called the dialyzer. I wonder if my landlord is working on the apartment upstairs because it's been banging all day and I know there's nobody up there.
I can hear the banging.
I wonder what in the world he's doing. Somebody's up there. So call the dialyzer and return dialyzer, not laser, dialyzer, and return to the blood. The renal clearance is the rate at which kidneys remove substances from the blood and can be used if a substance is completely filtered and not reabsorbed. It can be used to estimate the glomerular filtration rate. The unit of measurement for this is milliliters of plasma per minute. How many milliliters of plasma are cleared of this substance per minute? For a substance to provide an accurate measure of renal clearance and glomerular filtration rate, the substance should be completely filtered, neither reabsorbed nor secreted. It has to be completely filtered. It has to have a very good filtration, or you can't use it to measure a great glomerular filtration rate or renal clearance. Which of the following form the inner layer of the glomerular capsule and wrap around the capillaries of the glomerulus?
Was it the, I wanted to say meson or macula densa?
Nope, those are in the distal convoluted tubule.
Oh, okay.
You're close though. You remember I was talking about that filtration membrane? The outermost part of the filtration membrane is what?
Is it B?
B is in Bravo, mesangial cells. It's not.
Okay.
What? Go back and look at,
Capillaries.
look at up here.
Oh, it's the podocytes.
I was just gonna
Podocyte.
say it's the
Yes.
podocyte cell body or whatever.
Think podocytes, it's podocytes. Think of the
Podo.
podiatrist, because that's what these are, is their foot processes. So call them podocytes, and yeah. But yes, that's exactly right. So moving on from the glomerulus, the nephron and the collecting tube, the renal tubule, newly formed filtrate from the renal corpuscle is going to enter the renal tubule, which consists of the proximal tubule, the loop of Henle or nephron loop, and the distal convoluted tubule. Looking at the different histology within the renal tubule, in the proximal convoluted tubule, it's simple cuboidal epithelium. What does it mean to be simple cuboidal?
It's like one layer of cells.
One layer, and what side, what's their shape like?
Cubes.
They're cubes. One other thing that we have here is these are covered. These are covered with microvilli. What do microvilli do?
Increase the surface area
Right. Why would we increase the surface area?
for absorption.
Right. So you will notice with the other cuboidal epithelium that we see throughout the nephron loop, we don't have that many microvilli in comparison. So what does that tell you about what's going to go on in the proximal tubule? It's going to be the major location for reabsorption. I'm about ready to go up and say something to him, but I won't.
I can barely hear it. It probably bothers you more than
It's startling me more than anything. And I don't know if it's my landlord or maybe someone they've hired. If it's my landlord, I'd go up there and say something. But if it's not my landlord, I definitely want to go up there and say something. In the nephron loop, so now leaving the proximal convoluted tubule, going into the nephron loop is a simple squamous epithelium. What is simple squamous epithelium important for?
doesn't it have elasticity?
Not really.
Okay.
Not really.
That's like in the bladder, that's different.
Yeah, that's transitional.
Yeah.
What about here?
Filtration.
Filtration or diffusion, right? Good job. Yes, Martin. As we move up, so this is the thin descending limb. As we move up, we're moving up the ascending limb. And now we have simple cuboidal epithelium with no microvilli. Are we having a lot of absorption here? We're actually having some reabsorption here, but not to the extent that we saw in the proximal convoluted tubule. We also have simple cuboidal epithelium in the distal convoluted tubule. So all of these places, except for in the thin limbs of the nephron loop, we have simple cuboidal epithelium. Looking at the collecting duct by itself, the filtrate from several distal convoluted tubules is going to enter one cortical collecting duct. So multiple collecting ducts. So multiple distal convoluted tubules are going to merge into one collecting duct. And this cortical collecting duct is going to become the medullary collecting duct as it enters the renal medulla. as it enters the renal medulla about right here, it's going to become the medullary collecting duct. Cortical collecting duct when it's up in the cortex of the kidney. Medullary collecting duct when it's in the medulla. At the bottom of the collecting duct, the tip of the medullary collecting duct, multiple medullary collecting ducts are going to form a papillary duct. Once the filtrate enters the papillary duct, it's now called urine. And the urine exits the papillary duct through the papilla of the renal pyramid into the minor calyx. You guys, let's take 5 minutes and we'll come back to right here.
See you in 5.
Thank you.
I'm going to go and see if my neighbor's up there really quick. My landlord, because if it's my landlord, I'll talk to him. If it's not, I'm definitely not talking to him. Okay. So that was my landlord up there. And so I think I told you that our neighbor passed away, and he's up there trying to clean up that apartment, and he's awesome. And yeah, he's just a neat guy. But that's what he's doing, and that's what the banging is. So I apologize, but I know that he works nights. So the fact that he's doing this during the day means that he's running on probably very little sleep. So I didn't complain too much.
That's good.
Yeah, he's a good guy. Which of the following is not composed of cuboidal epithelium?
Would it be B because it's thicker?
Nope.
No.
No. Which is not composed.
Thin.
Yep, it's a thin one. I love your German Shepherd puppy there, Becky. He's gonna have his nose in your face there.
Well, I have food cooking for dinner and it's making me hungry. So now I'm eating something and he's now my best friend. Throughout the rest of the class, he was sound asleep on the bed. And now he's just in my face because I'm eating. Unfortunately, you talked about sodium, so now I'm eating chips.
Okay, good. Well, good. All right, good. Good. So nephrolithasis, lithasis. I think I'm going to say it nephrolithasis because my mother's not here to correct me.
Lith means stone.
Yes. And what does nephro mean?
Kidney.
Okay, so kidney stones. Formation of renal caliculi, another name for stones or caliculi. They occur whenever there is a supersaturation in the filtrate of sodium and hydrogen ions and uric acid. So when there's a supersaturation, anytime when there's a supersaturation of a material, things are likely to crystallize out. That's what's occurring here. They can form in the nephron loop, the distal tubule, or the collecting duct. Most pass unnoticed. If you look here, here's one right in the renal pelvis. They can also adhere to the tubular epithelium or in the collecting duct. And they can break off. No, Leo, they can break off and lodge in the calyces, renal pelvis and ureter.
I always thought kidney stones came from calcium.
They can form from calcium too.
Okay.
But usually it's multiple ions playing into it.
Okay.
Because I think if I remember right, most are produced from calcium and magnesium. So just to a little bit of some definitions here. Tubular reabsorption. Substances must pass from the filtrate in the lumen inside of the tubule across or between tubule cells into the interstitial fluid, and finally cross between across or between the endothelial cells of the peritubular capillaries to re-enter the blood. So they have to pass through the cells, have to pass through these cells or in between them to enter the blood. In tubular secretion, substances move in the opposite direction. They're going to move through, they're going to move from the blood into the filtrate that's within the lumen of the tubule. So substances can be transported across the tubular cells by two routes. Shoot, that scared me. Sorry, guys. They can move in between the cells, a paracellular pathway, paracellular routes, or transcellular routes, meaning they move through the cells. Pericellular, meaning substances pass between the adjacent cells. Tight junctions these tight junctions will allow small ions and water to move passively between them. So this is going to occur in passive transport, not active transport, passive transport. In transcellular movement, meaning they're moving across the cells, they're going to actively cross the apical membrane, the top membrane that's facing the lumen, and exit via the basolateral membrane into the blood. So in this picture right here, the lumen would be right here. The blood would be right here. Some solutes are going to move passively down their concentration gradient, while others are going to move against their concentration, requiring active transport. Tubular secretion, putting something from the blood into the filtrates, is always active and must occur via transcellular routes. So they have to move in the cells, through the cells, not in between them. Reabsorbed solutes that enter the interstitial fluid can move via the transcellular or paracellular routes. So reabsorption, things are moving from the filtrate in the lumen into the blood. Secretion, moving from the blood into the lumen. Reabsorption can occur via the transcellular route or the paracellular route in between the cells. Most substances that are reabsorbed or secreted via the transcellular route do so by carrier-mediated transport. They have to have a carrier in order to transport them across the cell membranes. They do this via three different possible ways. Facilitated diffusion, where things are going to be transported. A carrier is going to transport something without using ATP. Something's going to get moved down its concentration gradient via passive transport using a carrier. Primary active transport is going to use ATP to move a substance against its concentration gradient. So carrier or protein pumps two or more substances in the same direction, symport pumps, or in opposite directions, antiport pumps. Secondary active transport. A concentration gradient is set up via primary active transport and is going to be used to drive the transport of another substance against its concentration gradient via another protein, carrier protein. Remember, we talked about this last week. You're building up the concentration gradient of one substance, and then you allow it to move down its gradient if it drives the transport of another substance against that substance's concentration gradient. These pumps can become saturated, meaning all the binding sites for that substance are filled. This is defined as the transport maximum. Substances that don't bind to a carrier because the carriers are saturated will remain in the filtrate and eventually be eliminated from the body in the urine. Guys, this is going to be important later. If you have to transport a substance, reabsorb a substance via a carrier or a pump, if that carrier or pump becomes saturated and you can't reabsorb any more than you're already reabsorbing from the filtrate, anything that's left in the filtrate is going to end up in the urine. If you run out of pumps because there's too much of that substance in the filtrate, you're going to find that substance in the urine. When you're looking at your strips, your urinalysis strips, look and see what substances should normally not be there. And think about, why are they there? Total saturation of protein transporters for a given substance in the renal tubules would result in what? So total saturation, transport maximum for a given solute would result in what? So here, substances that cannot bind to a carrier because that carrier is completely saturated will most likely remain in the filtrates. So total saturation of protein transporters for a given solute in the renal tubules would result in what? I can only see Becky's face right now.
Oh, D, because it eventually gets dispersed in the urine.
Booyah, yes. So appearance of that salt, it's eventually going to be found in the urine.
All right.
Good job. Reabsorption in the proximal tubule. So remember, this is where we have the most amount of microvilli. This is where the most amount of reabsorption is going to occur. The main roles of the proximal tubule is reabsorption. Large quantities of ions are reabsorbed to maintain electrolyte homeostasis. Almost 100% of nutrients, including glucose, amino acids, water-soluble vitamins. Leo, no. No. Sorry, disciplining my cat. Almost 100% of nutrients, including glucose, amino acids, water-soluble vitamins, and lactic acid are reabsorbed here. Bicarbonate ions, remember that's a base, that are critical to acid-base balance are all reabsorbed here. About 65% of the filtered water is reabsorbed to maintain fluid homeostasis. So we're going to talk about reabsorption of bicarbonate. This reaction in the filtrate occurs because of the sodium hydrogen antiporter activity. So sodium gets reabsorbed, hydrogen gets secreted. I'm going to start building up a series of things for you. Okay. So here's my lumen. Here's my tubule. Lumen that containing filtrates. Blood plasma. Okay. I have a carrier. Sodium moves one direction. Remember how much we like sodium. Sodium moves one direction. Potassium, hydrogen ions are always going to move the opposite direction. So if hydrogen ions are secreted, sodium is reabsorbed. If hydrogen ions are reabsorbed, sodium is secreted. So we're starting with this idea here.
So you said if hydrogen ions are secreted, then sodium ions are absorbed and vice versa?
Yes.
Okay, thank you.
So carbonic acid, we've seen this equation a couple times. Remember, memorize this equation right here. Carbonic acid is converted from carbon dioxide and water to via carbonic anhydrase. Carbon dioxide will diffuse into the cytosol of a cell. So in the lumen, it's going to diffuse, the cytosol is going to diffuse into the lumen, so into this, bear with me. Carbon dioxide diffuses into the simple cuboidal epithelium of the lining of the tubules, where it gets combined with water to form hydrogen ions and bicarbonate because it combines with water and then it immediately breaks down into hydrogen ions and bicarbonate right here. This process repeats as hydrogen ions are secreted back into the tubular lumen and sodium gets reabsorbed. Bear with me, one more thing. If hydrogen ions get secreted, bicarbonate gets reabsorbed also. They're working in, so this is the same with sodium here. So this process is going to allow cells of the proximal tubule to reabsorb about 90% of the bicarbonate, meaning it's going to reabsorb 90% of the base, a key component of the body's ability to maintain pH. So looking at this, that was the written description. Here we have a visual description of it. And I'm going to zoom in just a little bit so we see it a little better. Hydrogen ions get secreted into the filtrate. They combine with bicarbonate in the filtrate to form carbonic acid. Stop that, buddy. Carbonic acid immediately disassociates into water and carbon dioxide. Carbon dioxide diffuses into the cell, where it combines with water to form carbonic acid. Carbonic acid again immediately disassociates to form hydrogen ions and bicarbonate. Bicarbonate gets reabsorbed, hydrogen ions get secreted. I like this drawing a lot better than my physiology drawings, and it's essentially showing the same thing. Reabsorption of sodium. So sodium potassium pumps, remember that this is another one. So hydrogen moves the opposite direction of sodium and bicarbonate. Potassium moves the same direction as hydrogen does, and opposite to sodium and bicarbonate. You guys do me a favor, write this down. If I'm writing things on this whiteboard, it's because I think they're really important. Write them down. Don't take a picture, write them down. You'll make me crazy if you take a picture because I want you to remember, and you'll do better if you write it down. Write it down. Yeah, Claire saw me. She was putting up her photo. I no, don't write it down. Write it down because you'll remember, because I'm going to bring it up again when we go through fluid and electrolytes.
So it says hydrogen and potassium go towards lumen, and sodium and the.
Just realize they're opposites of one another.
Okay.
More than anything, understand they're opposites of one another.
Okay. So when one, I think I remember asking, it's like a magnet, they oppose each other. So whatever way sodium goes, like potassium goes the other way.
Yep. And whenever bicarbonate goes one direction, hydrogen
Hydrogen
ion,
goes the other way.
and the same thing with potassium.
I do have that written down from, I think before we talked about it.
Awesome.
All right.
Awesome. So sodium potassium pumps are going to create and maintain a gradient by transporting sodium into the interstitial fluid through the basolateral membrane. Remember that basolateral membrane is right next to the blood. It's this membrane right here. It's right next to the blood. This is the apical membrane. This is the basolateral membrane. They create relatively low sodium concentrations in the proximal tubule cells, keeping the concentration of sodium low. This low concentration of sodium is critical for allowing active transports of other solutes. Movement of sodium can occur in two different ways. It can be facilitated diffusion using ion leak channels in the tubule cell surface, ion leak channels, or active transport on the apical surface. Carrier proteins specific for sodium can enable diffusion, facilitated diffusion. Sodium symporters, transport of sodium with other substances like glucose. Antiporters, sodium and hydrogen antiporters, bringing sodium into the cell while secreting hydrogen ions. All three of these types of proteins are going to transport sodium down its concentration gradient into the tubule cells. So all three of these are going to work to allow sodium into the cell down its concentration gradient. Reabsorption of glucose anions and chloride. You guys, all of these are going to get moved against their concentration gradient by using secondary active transport. So sodium glucose symporters use a sodium gradient that's been developed by that sodium potassium pump to move both sodium and glucose by secondary active transport. This is also used to transport amino acids from the filtrate, reabsorb amino acids, reabsorb lactic acid, reabsorb sulfate, reabsorb phosphate. Reabsorption of sodium also leads to reabsorption of anions like chlorine because chloride follows sodium. It's the balancing ion for sodium. As sodium passively is transported out of the lumen accumulates a net negative charge. As we keep moving sodium out of the lumen, keep moving it out here, it's going to develop a net negative charge if we keep pumping out positive sodium out. This creates an electrical gradient that pushes the negatively charged chlorine via a transcellular route into the cell. Or paracellular, I knew that wasn't right, paracellular route. So chloride also follows sodium. Now, so remember, we're going to use the sodium transporter to move glucose across the from the filtrate back into the blood. Why do we sometimes see glucose in the urine? When there's too much glucose in the filtrate, the transport maximum, TM means transport maximum, transport maximum. Remember, this is when all of the transporters are saturated. Transport maximum, TM. When there's too much glucose in the filtrate, the transport maximum is reached before we can absorb all of the glucose. And the excess glucose will therefore be found excreted in the urine. This results in hyperglycemia. With diabetes mellitus, there's defects in either the production of insulin, type 1 diabetes, or response to insulin, type 2 diabetes. And the cells are unable to uptake all of the glucose. The result is that the filtrate has a high glucose content. And when you reach that transport maximum, where you can't reabsorb any more glucose from the filtrate, that glucose is going to be found in the urine.
Is that also that glycosuria or something?
Glycosuria, yes. That means glucose in the urine.
Got it. It's right in front of me. Just kidding.
You're all right. You're all right. Yes. So with normal glycemia, you're going to get maybe some glucose in the filtrate, but you're not going to get an excessive amount. You're not going to get so much in the filtrate that the carriers become saturated and can't reabsorb anymore. When there's too much glucose in the urine, it's too much glucose in the blood. More of it is going to be found in the filtrate, and there's not going to be enough transporters to reabsorb it all. And so they get saturated and you find glucose in the urine. And because there's increased solute concentration, because there's glucose in there that should not be in there, the result is that you get more water in the urine also. This is why people with type 1 diabetes, development of type 1 diabetes, get really thirsty, is because they're losing water to all the glucose that's being found in their urine. So this summary slide, sodium potassium pumps move sodium out of the proximal tubule cell into the interstitial fluid, creating a sodium concentration gradient via second primary active transport. The sodium and glucose are moved into the cell from the filtrate via sodium glucose importers, using the energy of the sodium gradient. Glucose is transported from the proximal tubule to the interstitial fluid via facilitated diffusion, which then diffuses into the paratubular capillaries. Moving forward, obligatory water reabsorption. We're going to reabsorb a lot of water, and the effect on electrolytes. Obligatory water reabsorption. There's a certain amount of water that you're always going to reabsorb. So obligatory water reabsorption occurs in the second half of the proximal convoluted tubule after sodium, glucose, and other organic molecules have already been reabsorbed. Because water is obliged to follow these guys, if you keep reabsorbing substances here, what happens to the solute concentration here? If they keep moving from here into here, what happens here?
Becomes less concentrated.
What becomes less or more? If you're pulling them from here over into here,
Oh, more.
more. What happens to the water flow then?
What was the question?
What
Second,
happens?
what was the second part? I mean,
If it gets really concentrated here, what happens to water flow? How's the water going to move?
slow.
Is it going to move slow?
Oh, it's going to move faster because it's going to,
And what direction is it going to move?
towards the concentration.
All right, so it's going to move towards here, right?
Yeah.
Okay. So that's your obligatory water reabsorption. That's what it is by definition. Water is obliged to passively follow these reabsorbed substances using osmosis and paracellular and transcellular movements. This can be facilitated via aquaporins that are water channels in both the apical and basolateral membranes, greatly increasing water reabsorption. As water is reabsorbed, the concentration of magnesium, calcium, and potassium increase in the filtrates because they're not moving into the reabsorption, favoring the reabsorption of these ions by diffusion. So as you reabsorb water from here, you're going to get increased concentration of ions here, like potassium, magnesium, and calcium. And then water is moving in here. And so those ions are becoming more highly concentrated here, resulting in them moving also into the reabsorption, being reabsorbed into the blood and the interstitial fluids. So solutes passively diffuse or are actively transported into the tubule cell and interstitial fluid. The resulting solute concentration gradient draws water into the tubule cell via aquaporin channels via osmosis. I am not going to go through all of this. This is a summary of what we just talked about, and we saw this before. This is a summary of all that we've just talked about with the reabsorption. Don't make it too difficult. Because of the great deal of active transport that occurs here, the blank of one's nephrons collectively accounts for about 6% of one's daily resting ATP and caloric consumption. What is it? Somebody tell me. You guys, where have we been talking about active transport happening? I can only see Becky and Claire. But you guys, where have we just been talking about all this active transport occurring?
Active transport.
Where's it occurring?
Is it
Is it the proximal convoluted?
It
yeah,
is.
A?
It is. Good job. Yes.
Uh,
Which of the following is not reabsorbed in the proximal convoluted tubule? What one did we not talk about?
D?
You know what? I think, let me say this differently because I don't want to, D actually is reabsorbed here. What was another one that we talked about that is not reabsorbed here, but is secreted?
Potassium?
No,
Just kidding.
what else could it be?
Sodium?
Nope.
Now it's just process of elimination.
Water? Glucose?
Nope. You guys, it's hydrogen ions. If you notice, they're not being reabsorbed here. This is reabsorption. This is secretion. They're not being reabsorbed. You see that? You only have hydrogen over here. And it's only moving into the lumen, meaning it's being secreted. You see that? I think I led you, first I led you in the wrong direction to what I said initially. So now, secretion in the proximal tubule, we're just stay with me for another 10 minutes. Things that are secreted in the proximal tubule, so they're introduced into the filtrate. Includes hydrogen ions, so definitely not reabsorbed, it's always secreted. Hydrogen ions, many drugs, and various nitrogenous wastes. In the first half of the proximal tubule, most uric acid is reabsorbed. Nearly all of it is secreted back into the filtrate in the second half of the tubule. We actually absorb, there's a certain amount of the uric acid you want in your body. Ammonium, creatinine, which is a byproduct of muscle breakdown, and small amounts of urea are also secreted. Drugs such as penicillin and morphine also have a significant renal secretion here. Once the filtrate is now, okay, now we're shifting gears, not talking about the proximal convoluted tubule, talking about the nephron loop. Once in the filtrate, once the filtrate is in the loop, 60 to 70% of it excuse me, 60 to 70% of water and electrolytes is going to be reabsorbed in the nephron loop. and most organic solutes. About 20% and 25% of sodium and chloride are going to be reabsorbed from the loop. Oh, you know what? I read that first question wrong. First comment. Read that again. When this filtrate is finally in the loop, 60 to 70% of the water that was in the original filtrate in the capsule has been reabsorbed. 60 to 70% of the electrolytes have been reabsorbed. Most organic solutes have been reabsorbed. In contrast, in the nephron loop, about 20% of the water that's in that filtrate and 25% of the sodium and chloride that's in the filtrate, now that's in the loop. So once it's in the loop, 60 to 70% of the water, electrolytes, and most organic solutes were reabsorbed in the proximal convoluted tubule. That's what this says right there. About 20% of the water and 25% of the sodium chloride will then be reabsorbed in the nephron loop. In the proximal tubule, water reabsorption is proportional to solute reabsorption. This is not what it's like in the nephron loop, though. So however, in the nephron loop, the filtrate's osmolarity changes drastically. Osmolarity, think of osmolarity. This is another one to remember. Write this one down too. Osmolarity means concentration. Osmolarity means concentration. So what that means is that normally in the proximal loop, when an electrolyte or solute is reabsorbed, water follows in the proximal tubule to maintain the osmolarity and keep them equal. However, in the nephron loop, the filtrate's osmolarity is not going to be the same in the interstitial tissue and in the fluid. It's going to change depending on the permeabilities. One part of the loop is going to be highly concentrated. One part of the loop is not going to be so concentrated. So cells of the thin descending limb, remember what that limb looked like? Descending limb looked like this. Cells of the thin descending limb is freely permeable to water, but much less permeable to sodium and chloride. The result is that water will move out of the thin descending limb via osmosis, but few solutes follow. Therefore, the osmolarity of the filtrate is going to increase as it passes down the descending limb and rounds the bend of the loop. The cells of the ascending limb are impermeable to water, but transport sodium chloride into the tubular cells with potassium chloride and sodium symporters. They rely on the sodium-potassium pump to create a favorable ion concentration gradient. So sodium-potassium pumps are going to drive potassium ions back into the tubule cell. As the filtrate passes through the ascending limb, it's going to lose solutes because sodium and potassium and chlorine are going to be actively pumped out. So that filtrate becomes less concentrated. The osmolarity is dropping. Remember, osmolarity equals concentration. As ions are pumped into the interstitial fluid. So in the descending limb, where the cells are permeable to water but not to solutes, remember we're talking about the part of the limb that goes down, descending limb, are permeable to water but not solutes. The filtrate becomes more concentrated, reaching about 900 milliosmoles, because water is actively diffusing out into the interstitial fluid. In the thick ascending limb, sodium and other ions are being pumped out of the filtrate into the interstitial fluid. And water movement is restricted. So now in the ascending limb, the solutes, rather than the water that's left in the descending limb, the water in the descending limb keeps leaving. The solutes in the ascending limb are now leaving and moving into the interstitial fluids. So water is restricted, reducing the osmolarity. And it reaches about 100 milliosmoles by the time the filtrate reaches the early distal convoluted tubule. And you guys, I think this is a great place to stop. We will finish this. I will put the first exam up, and I'll give you 2 weeks to do it, but I need the second exam up. We do have to have 3 exams and a final before the end of the semester. So I really need to get that out. You'll have 2 to 3 weeks to take it.
Sounds good. Thank you.
But we will come back to this. We will finish it. And we will have you talk about the fluid, electrolyte, and acid balance, acid-base balance. And we will have a lab on the digestive system. And I do have a frozen liver. You'll have to look at it. All right. You guys have a wonderful weekend, okay?
So we
Thank
are,
you.
we
You
do.
too.
Have class next
Go
Friday,
ahead. I'm sorry. Go ahead.
right? We have class next Friday.
Yes, we do.
All right. Well, I'll see you then.
See you then. Zena, are you there?